Welcome to the Yale20. My name is Eric Jordan. I'm one of the internal medicine residents.
And I'm Jeff Connors. I'm one of the pulmonary and critical care faculty and the associate program director for the internal medicine residency. And today we're going to be talking about shock.
This talk is divided into two parts. In the first part, we will discuss the normal physiology of the body and then the abnormal pathophysiology which lead to states of shock. In the second part of the presentation, we will discuss, as in all Yale20 videos, first the initial evaluation of someone who might be in shock, the diagnosis and treatment of the different types of shock, how to have an effective, clear, and concise write-up of a patient with shock, and finally, some summary take-home points. To start off, imagine you are on your critical care rotation in the ICU and you get a page such as this one to evaluate a hypotensive patient. One of the questions you should be asking yourself is, does this patient have shock? Initially, you might think so. But Dr. Connors, tell me, what would be a good place to start to understand if someone is in shock?
I think a good place to start is to think about the definition of shock. So a strict definition is that shock is a state of cellular and tissue hypoxia due to reduced oxygen delivery and or increased oxygen consumption, inadequate oxygen utilization, or both. And for anyone who's studied economics, keep in mind the concepts of supply and demand. So to put this in simple terms, the body's tissues require a certain amount of oxygen, and if that supply of oxygen decreases below what's being demanded, then you've led yourself to a state of shock. The supply of oxygen, or the oxygen delivery, is denoted here as the DO2. And this describes the amount of oxygen in millimeters that reaches the systemic capillaries every minute. That oxygen is subsequently used for energy production in the electron transport chain to generate ATP. However, if there's not enough oxygen, the cell will go down a different metabolic pathway of anaerobic metabolism, which is much less efficient in terms of generating ATP and also produces lactate as a byproduct. Therefore, lactate is one of the indicators of how well tissues are being perfused. So let's take a look at the importance of lactate and its relationship to oxygen delivery as evidenced by the graphs on this slide. In the first graph on the left, you can see that serum lactate has a prognostic value for critically ill patients, in that the higher the initial serum lactate is, the higher the patient's mortality. And you can also see that the longer it takes to clear lactate levels also indicates a patient who is going to have a higher degree of mortality. And then if you look at the graphs on the right, you can see that even with the normal cardiac index, as the body accumulates an oxygen debt, lactate levels start to build. Therefore, it's important to correct oxygen deficits as soon as possible.
To understand why the body might go into oxygen debt and build up lactate, it is important to understand a few equations that we will keep coming back to. The first is the cardiac output, which is the product of the heart rate and the stroke volume. The next is the mean arterial pressure, which is equivalent to the systemic vascular resistance, meaning how much the vessels are vasodilated or vasoconstricted, times the cardiac output. And finally, there is the delivery of O2, which depends on the cardiac output multiplied by the concentration of O2 in the blood, also known as the CaO2. The CaO2, in turn, depends upon a constant known as the oxygen binding capacity of hemoglobin, times the amount of hemoglobin, which can be reduced in conditions like hemorrhage or anemia, multiplied by the SaO2, or the oxygen saturation of hemoglobin. This is added to the amount of oxygen dissolved in blood. However, this term is very small and is generally insignificant. If you are able to remember and understand all of the equations I just described, then you will have a good understanding of why the body can go into oxygen debt and therefore shock. The equations are again displayed, however this time in a graphical format which displays how they are all connected. If any one of these parameters were to decrease, such as the systemic vascular resistance in sepsis, then the body can go into shock. It is also possible for multiple components of these equations to be affected at the same time, such as in the case of hemorrhagic shock, in which the preload is reduced, but there is also less hemoglobin present to carry oxygen.
Now, the term shock is a general term, and I think it's helpful to break down and think about the specific types of shock. So you might appropriately ask at this point what type of shock a patient has. And therefore, before we put our money down on any specific cause, let's take a look at the different classifications of shock.
Sure thing, Dr. Connors. As we look at the list of different types of shock seen here, it does seem sort of overwhelming, though. There's cardiac shock, there's obstructive shock, hypovolemic shock. How do you really make sense of this all?
Right, and that's not even counting distributive shock, septic, neurogenic, anaphylactic, etc. And so fortunately, the nice thing is that each of these many types of shock really fall into three large categories. And so you can put these into some failure of the pump itself, a failure of the ability to have volume within the vessels, and then, of course, there's the failure of those vessels themselves.
Okay, I see. So this makes a lot more sense now. So you're saying that cardiac shock and obstructive shock fit into pump failure, whereas things with volume would be hypovolemic and hemorrhagic shock. And then all these others, from distributive down to endocrine, all fit into issues of blood vessel tone.
Yeah, that's exactly right.
Great.
So now let's take a look at some of the specific etiologies of these shocks like we were just talking about, as well as some of the initial tests or criteria that can be used to diagnose the form of shock. So pump failure can be caused or is known as cardiogenic shock or cardiac shock, in which the cardiac output is greatly reduced due to causes such as cardiomyopathy and arrhythmia, or even mechanical failures of the heart, including severe valvular stenosis or insufficiency, or defects in the myocardium like a severe ventricular septal defect or a free wall rupture. A similar but distinct category of pump failure is obstructive shock, in which the heart, usually the right side of the heart, is unable to push against the higher pressures in the lungs from something like a pulmonary embolism or severe pulmonary hypertension, or if there's external compression from a tension pneumothorax or pericardial tamponade, resulting in inadequate right ventricular filling, which of course a few cardiac cycles later results in inadequate left ventricular filling and shock. Decreased volume, which is sometimes difficult to assess and could be a lecture unto itself, can lead to hypovolemic shock, and a specific subset of hypovolemic shock is hemorrhagic shock, in which not only is there decreased effective circulating volume, but also less hemoglobin to help deliver oxygen to the tissues. And finally, there are etiologies of shock that decrease blood vessel tone, and honestly, in the medical ICU, these are the ones we see most commonly. This includes septic shock, which is classically defined by the SIRS criteria, shown here along with confirmed or suspected source of infection, and of course that was recently updated to include analysis of SOFA scores in 2016. And then of course there's endocrinologic shock, which decreased blood vessel tone is unable to be maintained due to decreased levels of cortisol. So what does the body do as a compensatory mechanism when shock develops? So let's go back to that helpful money analogy we talked about earlier. When someone's in financial debt, which is analogous to our oxygen debt, you can either try to make more money or dig into your savings. The body handles oxygen debt similarly by trying to decrease the delivery of oxygen or by reaching into our oxygen savings, which is analogous to increasing the extraction of oxygen from the blood. So let's look a little more closely at how the body increases the delivery of oxygen.
The body can increase oxygen delivery by increasing heart rate and the other parameters described in our DO2 equations. In cardiogenic and hypovolemic shock, patients will clamp down their blood vessels to increase the SVR and therefore the MAP, which clinically results in cold extremities. If someone is volume down, they will have clinical features such as oliguria and dry mucous membranes. Patients tend to be tachycardic in multiple forms of shock, such as hypovolemic and septic, and when patients are exposed to low levels of O2 over long periods of time, they can mount an increase in hemoglobin production, although this does not happen acutely. Looking at the second way the body responds to an oxygen shortage, we see that the fraction of oxygen released from hemoglobin to the tissues can be increased in a process called the Bohr Effect. Here, we see a hemoglobin-oxygen dissociation curve. The blue line in the middle represents the normal state, in which at a given partial pressure of oxygen, there is a corresponding percent saturation of hemoglobin. Under normal conditions, hemoglobin can carry up to 4 oxygen molecules, and usually only dissociates 1 molecule to the tissues. However, in states of cellular dysoxia, lactate builds up, the temperature increases, and the pH drops, which results in conformational changes of hemoglobin and an associated low-affinity state where the oxygen can more easily dissociate from the hemoglobin and be delivered to the tissues. This is shown graphically by the shift of the dissociation curve to the right.
So let's take a look at our financial analogy again. In the finance world, we have credit scores, which indicate how well a person pays back their debts. Similarly, we can look at the SCVO2, or the central venous O2 saturation, to give us an idea of how much the body is digging into its savings and how it's dealing with the accrued oxygen debt. To get into a little more detail, I'll first define a few terms. So the central venous oxygen saturation, the SCVO2, which can be measured through a central line, shows us how much oxygen is being extracted from the blood, but it puts a little more weight on what's being extracted from the head and the upper extremities and somewhat misses what's being extracted from the lower extremities. So it's not an exact measure. The next, more exact measure is the mixed venous oxygen saturation, which consists of a mixture of blood coming from the upper body, the lower body, and even the coronary arteries. Now, while this is a better number, it's a little more of an involved process to actually obtain and requires the placement of a Swan-Ganz catheter. Despite the central venous oxygen saturation being slightly higher than the mixed venous oxygen saturation and not quite as exact, it correlates well with the mixed venous oxygen saturation and therefore can be used reasonably reliably as a diagnostic measure. Using these numbers and the arterial oxygen saturation, we can determine the oxygen extraction ratio, which is simply the arterial O2 saturation minus the central venous O2 saturation over the arterial O2 saturation as the denominator. The importance of this number will become apparent in a bit and can be better understood by taking a look at a few examples. So for instance, if the arterial oxygen saturation is 100%, as it should be, and the venous oxygen saturation is 75%, as it would be in a normal, healthy subject, when we plug into the formula, we see a 25% extraction ratio, which again is considered normal. When in states of cardiovascular or hypovolemic shock, you may see a scenario in which the SCVO2 is 50%, and therefore the extraction ratio is also 50%, meaning the body is increasing its ability to take oxygen out of the blood and indicating some degree of oxygen debt in the tissues. Finally, in cases such as septic shock, where there may be a high SCVO2 and a low extraction ratio, and again, this is in the latter stages of septic shock, it indicates that the body is actually not able to extract oxygen as it should, and this is due to cellular ischemia and tissue death. One final note is that making a continuous monitoring of these variables to see how they change over time instead of using an absolute value at any given point will yield a better overall clinical picture of the patient's status.
We can match up each of these extraction ratios with what is occurring on the cellular level. When the delivery of O2 is low, as in the case of cardiogenic or hypovolemic shock, the tissues will attempt to extract as much oxygen as possible. But why might the body have a low extraction ratio, as in the case of septic shock? Recall that the definition of shock includes a component of inadequate oxygen utilization, and this is exactly what happens in septic shock. Due to bacterial endotoxin, which blocks the actions of pyruvate dehydrogenase, as well as oxidative stress, which can inhibit cytochrome oxidase and other proteins of the electron transport chain, cells are not able to adequately use oxygen. This process, called cytoplasmic hypoxia, refers to a defect in the oxygen utilization of mitochondria. Another way to look at the difference between different types of shock are whether they affect the macrocirculation, meaning the major named arteries and veins, or the microcirculation, meaning the arterioles, venules, and capillaries. The macrocirculation is affected in cases of cardiac and hypovolemic shock, whereas the microcirculation is affected in cases of sepsis. This concept is illustrated here, where we can see dark field images of the microcirculation. A normal image appears on top. However, in the case of septic shock, due to inflammation from leukocyte adherence and activation, there is endothelial dysfunction and vascular leakage, which results in heterogeneity of blood flow, meaning some capillaries have essentially stopped flowing while others have greater flow. This causes shunting of blood from the arterioles to the venules and hypoxemia of the capillaries, and is another reason why we see a low extraction ratio in septic shock. However, in the case of low oxygen delivery, there's an equal distribution of blood flow across the capillaries and no endothelial dysfunction, which allows for a higher extraction ratio.
So let's look one more time at our FICO score analogy for the body, which is the SCVO2 and extraction ratios. When the SCVO2 is low, we know the body is taking up more oxygen from the blood because the delivery of oxygen is also low. We also know that it's bad when the SCVO2 is high because the body is not able to utilize the delivered oxygen, such as in those septic states we were just discussing. But what about when the values are normal? Does this mean the body's normal? Well, unfortunately not. It's a little more difficult to interpret these values because it could be a case of improving parameters for something like cardiogenic shock, or it could be normal because there's an overlap of the different types of shock, some causing high extraction rates, some causing low extraction rates, and in the end, the SCVO2 looks falsely normal. So to wrap it all up, the SVO2 is helpful for confirming the type of shock we think the patient has, as well as indicating whether or not there may be an overlap of shock states. For instance, in the case of septic shock, we would expect the SVO2 to be normal or elevated, but if it is low or low normal, we can presume that there may be an additional type of shock occurring concurrently and or a patient in septic shock who has yet to be adequately volume resuscitated.
That's everything for this lecture on the pathophysiology of shock. Thank you for listening, and please take a look at part 2 of this lecture, in which we will describe the general approach to a patient with shock.